I thank our Honorable Chairman, Professor Titial sir, and I also thank AOS and the audience here, my friends, for giving me this opportunity to present something which is totally synthetic. Namrata ma'am was telling some biosynthetic, but this is completely synthetic because endothelium, as we know, doesn't have a propensity to regenerate by its own. There are some efforts going on to work on regenerative therapies, bring up stem cells in endothelial dysfunctions, but my talk today will be confined to a novel synthetic corneal endothelial substitute, I would call, in cases of chronic corneal edema. It's a phase 2 safety evaluation study, and I'll be presenting the interim reports. I do not have any financial interest. However, the product is from an Israel company. As we know, corneal blindness due to endothelial dysfunctions vary from 3.8 to 11%. 1 to 2% are pseudophakic corneal edemas. And risk of graft rejection after keratoplasty can go as high as 30 to 40%. And endothelial transplant, it is the various reports are given between 2 and 10% of graft failure prevalence. So, in country like ours, it is 1 out of 70 needed corneas we get for transplants. So, this justifies the role for an endothelial substitute which forms an impermeable barrier to fluid and reduce the passive diffusion of fluid into the corneal stroma, thereby keep the cornea in a relative dehydrated state. So the purpose is to evaluate the safety of implanting a synthetic corneal endothelial substitute in cases of chronic corneal edema, of course in selected cases due to endothelial dysfunctions. This is an open label phase 2 clinical evaluation, and surgical procedure I will show you. Outcomes, the primary outcome is the corneal thickness, central corneal thickness. Of course, the secondary outcome is also pain and visual analog scale. So this is how, this is a pseudophakic corneal edema. The loose epithelium is removed. The central 7 millimeter I mark. A careful decimeter excess of the central 7 millimeter is made in a very conventional way, just like as we do for any endothelial keratoplasties. After having removed, I'm sorry, I'll play again. This particular material is completely a synthetic material, and it is just like IOLs. It is as similar to a Rainer foldable IOL. That's what the company says. I'm sorry for the length of the video. It looks quite long, but I have no option of advancing the video. I'm sorry. It prevents diffusion of fluid from the aqueous. It's an acrylic material similar to that of Rainer intraocular lenses. The thickness? The thickness is 25 microns. As like any other endothelial keratoplasty, we make inferior peripheral iridotomy, and this is how the material is. Yeah, just like a contact lens, but much thinner. And being a synthetic substitute, we don't have to worry about damaging the endothelial surface, we can just meddle the implant in whatever way we want. Once when it is placed in the center, I use a gas bubble and then make it well centered within the 7 millimeter zone. The overall diameter is 6 millimeter, and I use C3F8 gas to fix. Meanwhile, I also give one primary suture through the synthetic implant to help them stay in place for the initial few months, maybe weeks or months. And finally, fill the chamber with 80% C3F8 gas. And we also have an F mark to find the correct orientation of the implant. So this is a representative case example, a pre-op day 1, day 7, day 14, months 1, 2, 3, 4, and also till month 6. We have follow-up data with central zone remaining very clear. The visual acuity gains in our series of 12 cases, baseline was on an average, the mean was 10 characters, ETDRS characters, which improved and stabilized over 55 characters over time. The corneal edema, it was 750 microns in the baseline, and now it is very much stable at 495 or 500 by month 6. It's another case example which shows the device is well attached over a period of time. We also have one patient who died in between due to some other cardiac illness, but we could retrieve the cornea, and we did subsequent histopathological analysis, and we found very good fibrous adhesion along the edge of the implant. So it was tough. It was not possible to even remove the implant even after death. Rebubbling, yes, we had some of the cases. We had frequent rebubbling in one of the cases 3 times, and if the implant is stuck there for more than a month, generally it doesn't detach. Early stages there were rebubbling requirements. To conclude, synthetic endothelial substitute improved vision, reduced corneal edema, and also it reduced pain scores, pain analog scale, and they were not associated with toxicities until month 6. And we are still in further follow-up of these cases. We look forward to having the global reports come up in 1 or 2 months. So this could be a good substitute for endothelial keratoplasties, at least in selected cases. Thank you.
Thank you. Very nice presentation. I think few points which you can highlight. One is because this is definitely a synthetic material. So attachment is the concern you rightly pointed out. You may require multiple rebubbling, and instead of one suture, if you put 2 sutures where you have equal support from either side, may decrease the requirement in these cases. And I think we would like to know how this synthetic material sustain the corneal function, because it doesn't have an endothelial pump. So how does it clears the cornea, which is people would like to know that.
All right, sir. I'll take up the first question. It is having one suture. Dr. Offer, who have brought up this technology, he, in his initial cases, he didn't have any sutures, but the implant can drop into the AC. And it's being 25 microns, it's very difficult to find it out also. So in order to facilitate the implant in place, not in place, it is the suture is meant only to facilitate resurgery for rebubbling. So it was advised that we use one single suture at 12 o'clock so that the device doesn't go down. But it's a good idea to have multiple sutures also till a good fibrosis at the edges happen. Number two, as we know, yes, nothing can replace endothelium. We all know it has got active pump mechanism which pushes fluid outside the cornea. But this one is aimed towards acting as a barrier towards the passive diffusion. So many of the cases, if we see, the central 6 millimeter of the implant zone remains clear. The rest of the portion will still be edematous in some of the cases. So this acts only as a barrier. It doesn't. It cannot also replace endothelium.
So why the F mark? Will the orientation matter?
Yes, because of the curvature. Because of the curvature, but it really doesn't matter much. But the device is made in such a way that it follows the base curve of the posterior cornea.
I think other things which are important is, one is the refractive index of this substance. Though it is a thin one, should have, almost similar to a cornea so that it doesn't cause another refractive this thing. And other thing is, as I remember, Mark Terry had initially for a DSEC, he used to, scratch the periphery and thinking that, DSEC lenticle will get attached with the fibrosis. If this is the concept here also, fibrosis of periphery, so you can scratch and get a fibrosis done faster.
Here we want the opposite. We want the peripheral endothelium to be intact because we want some endothelial cells to work in the periphery for the peripheral cornea to be remain.
No, just where you're scoring, there is to have a stromal scoring also. That you have a better attachment of a lenticule. DSEC, which was not actually required in a normal DSEC surgery. Here I think that may be a one point, where
that can induce fibrosis also.
An early attachment of this synthetic lenticule. Yes. But it's a very interesting, I think we need to wait for some more time to get the results.
Yeah.
And a proper case selection is also important in these cases.
Exactly.
I think, early cases would do better, like you do for a DSO or a DVEC. So similarly, this will also be very chronic cases may not be of very great help.
Correct. Yeah. And also viral cases, we shouldn't touch. And we are also waiting for long-term reports because we don't know a synthetic material, does it cause any stromal lysis for the thinning of cornea. All those we don't know for the long term. All that we have is 8-9 months data, the longest follow-up in our series, and most have crossed 6 months.
Thank you.